most often you will be given a LABC case only. So our discussion will mostly be focused on a case of LABC. Side by side, we also will be discussing a few things about early breast cancer and breast cancer with metastasis. Okay. Yes.
Okay, sir.
Okay. Am I audible to everyone? If you have any problem, you can text in the chat box, right? Okay. Karishma, you can start presenting. Yes. Start, ma.
Detail. Year old home
Yeah.
house
Your voice is not clear.
belongs to low
Yeah.
social.
You are not
Hello,
audible, Karishma.
hello, sir.
There's an interruption in your voice. Yes.
Sir, now I am audible.
Yes. Now it's all right. Yes. Present.
Okay, sir.
Hmm.
55-year-old woman,
Hmm.
Mrs. Revati, educated up to 12th housewife, residing
Yes.
in Chetpur, belongs to low socio-economic class.
Yes.
Next slide.
Yeah.
The patient present with the chief complaint of lump in the left breast for past 6 months.
Good. Yes.
History of presenting illness. Patient was apparently normal 6 months back, after which she noticed a lump in the left breast while onset,
Yeah.
initially small in size, gradually increased and attained the current size, not associated with pain.
Okay.
Next slide. No history of nipple discharge, no history of recent onset of nipple retraction, no history of fever, trauma, no history of loss of appetite, no history of loss of weight, no history of bone pain, no history of chest pain, no history of difficulty in breathing, no history of cough with hemoptysis, no history of jaundice, abdominal pain or distension, no history of headache, blurring of vision, seizure, no history of swelling elsewhere in the body.
Okay, Dr. Karishma. So you said it is an insidious
Kartika,
swelling,
sir.
right? Huh? You are?
I am Kartika, sir. Kartika.
It's coming. Karishma Harini is presenting.
She is screen sharing, sir.
Oh, she's sharing the screen, right? Okay, you are Karthika, right? Okay.
Yes, sir. Yes, sir.
Now you said it's an insidious onset, right?
Yes.
Of 6 months duration.
Yes, sir.
Okay. So suppose you get a case of swelling in the breast of 2 days or 3 days duration. What will immediately come to your mind, ma?
Any
Yes.
trauma?
A swelling. Yes, trauma. Anything else? So
Inflammatory
traumatic
condition.
swelling can present in a very, very, very short duration, right? Anything else?
Inflammatory condition,
Yes.
sir.
What is it?
Acute mastitis.
Janavis of swelling, yes. Mastitis, especially in a lady who is lactating, sudden onset like that, it is almost confirmatory that it is mastitis. Okay, which might eventually
Yes,
lead
sir.
on to formal breast abscess. So the timing and duration chronology is very, very important. As I have time and again telling, chronology by means of the duration of the tumor itself, you can most often make a diagnosis, right? Okay. So she's complaining of pain here.
No, sir. No pain, sir.
You should tell that first, ma. Okay. You said
Okay.
the patient is complaining of lump. No. In history
Yes,
of
sir.
present illness, you have elaborated the swelling. Next, immediately you should tell is a pain. Okay.
Sir,
How does
I
a
wrote
pain
it.
present in CA
Pain.
breast? Previous slide it is there. Go back to
Yes, sir.
that. Previous slide. Not associated with pain. Okay. Right. When does pain manifest itself in a CA breast?
Sir, at a later stage only
Or
the
what is
pain
the
will.
relationship of it? Yes. So pain usually is a late presentation in case of malignancy, and it is due to what? What is the reason for pain in a malignancy at a later stage? This, tell me. Yes,
Breast tissue.
due to
Hello.
yes. Tell me. What is the pain in a? What is the reason for pain in a CA breast?
So due to involvement of the um,
Yes,
ligament of
underlying
Cooper.
nerves, right? So the breast is
Yes.
situated on pectoralis major muscle. Pain usually when the malignancy progresses, it will infiltrate the surrounding tissue. Mostly the nerve fibers situated in the surrounding structures, when they are infiltrated only, the pain becomes more. Okay? That is the
Okay, sir.
commonest presentation or reason for pain in a malignancy. You should remember. So as the malignancy progresses, nerve infiltration occurs and pain ensues. That is one reason. Second one is due to ischemia and sloughing out of a fast growing tumor. So malignancy becomes very fast growing, the blood supply is cut off and ischemia and infection occurs. That is maybe one second reason. Okay.
Okay.
Is there any other specific type of breast cancer where pain can occur? Any specific pathological type of breast cancer where pain can be present? Kavya and Kiran is telling it is inflammatory cancer. You should immediately tell, okay? There is a type of
Yes, sir.
pathological type of breast cancer which is inflammatory, say, which will almost be looking like mastitis, right? So kindly remember, pain is not an initial manifestation in CA breast. It is usually a late presentation in CA breast, and the reason for pain in a late stage in a breast is infiltration of nerves, sometimes due to ischemia due to exuberant growth or excessive growth where the volume is very big, the blood supply is cut off and ischemia occurs. And one special type of CA breast where pain can occur is inflammatory CA. This should be your instant answer, okay? Yes, Karthika, proceed now.
Yes, sir.
Okay. So go to the previous
Pass.
slide. Other symptoms also we'll see. No, go to the previous slide. Okay. No history of nipple discharge. Right. I hope we have discussed more about what are the types of nipple discharges. Would you like to
Yes, sir.
revise that? Quickly tell me what are the type of nipple discharges possible.
Sir, pus in case of abscess.
Oh, good.
Milk in case of galactocele and galactorrhea.
Yes.
Blood in case of carcinoma, breast, ductal papilloma.
Yes. So profuse blood is usually due to the papilloma. Okay. In CA breast, blood discharge can occur, but it is not very profuse. Profuse bloody discharge in nipple is due to duct papilloma. Okay. Any other discharge?
Greenish discharge.
Greenish discharge. Duct
Ectasia.
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 Okay. Duct ectasia, most often due to fibrocystic disease of breast, or what you called as fibroadenosis. Right? Fibroadenosis or fibrocystic disease, you can get greenish discharge. Okay. Reason onset of nipple retraction. What is the reason for retraction of nipple? What is the pathology behind that?
Sir, infiltration lactiferous
Yes.
duct, sir.
Infiltration of lactobacillus. Very good. Okay, we'll go to the next slide. So all other symptomatology is to tell about
Rule
the
out the
extent of the
metastasis.
disease. Metastasis, exactly. Okay, past history.
Past history. No history of previous similar illness in the past. No history of diabetes mellitus,
Yes.
hypertension, asthma, tuberculosis, epilepsy, jaundice, previous hospitalization. No history of previous surgeries.
Yes.
No history of previous irradiation. No history of intake of OCP.
Okay. Right. So here in this past history, I want you to mention about any interventions regarding breast complaints done in the past. We should specifically tell, because there are risk factors occurring in a woman which can stratify or classify the patient's risk for developing cancer, right? How will you classify the risks? Do you have any idea of how you classify the risks? In in earlier days, we used to classify it as major and minor risk. Now, what is the nomenclature for classifying the risk? Anybody can text? Those who know? Do you catch my question, Kartika? Yes. So Karthik and Gauri are saying modifiable and non-modifiable risks. Okay. So modifiable risks are your life habits or taking or extraneous hormones. Like non-modifiable is your age, your gender. Those things are non-modifiable. Okay. Kartika, do you hear me?
Sir. Sir.
Huh? Am I audible? Okay.
Yes.
So here, yep, any lady who is undergoing some investigations for breast complaints, not essentially a CA breast. For example, in her early 20s or 30s, she goes, has some breast complaints for which she goes and does a ultrasonogram or a biopsy, then it itself is given as a risk factor. So you should mention past history, right? All students kindly note, when you give a past history for CA breast, you should mention whether there is present or absent history of any interventions in the breast, whether investigative or therapeutic done. You should mention. In this lady, what you should tell is the patient does not give any history of any interventions for breast complaints done in the past. That is, be specific about it. Okay, because if there is such positive complaints, it becomes one of the risk factors. So you should mention it, right? Okay. Irradiation is very important.
Yes, sir.
Yes. So irradiation is also a risk factors for CA breast. Okay. Next slide. Yes.
Diet, normal or of alcohol.
Okay. There's an interruption in your voice.
Hello, sir. Am I audible?
There is a lot of interruption, Ma. Make sure that your connectivity is right. Yes, proceed.
Sir, am I audible now?
Yes, proceed.
Yes, sir. Menstrual and marital history. Age at menarche is 13 years. Regular cycle 5 by
Yes.
30. No normal flow, no clots. Age at marriage 17
Yes.
years. Obstetric history P2, L2, A0. Age at first childbirth is 19 years. Normal vaginal delivery. Breastfed for 1 year. Second child 22 years. Normal vaginal delivery. Breastfed for 1 year. Age at menopause is 46 years. No history of hormone replacement therapy.
Okay. What do you understand from this? Anything abnormal or harmful or adversely you can notice in this history?
No, sir. Everything is fine,
Okay.
sir.
Right. What is the importance of menstrual history or gynecological history with relation to CFS?
Early menarche, late menopause.
Are risk factors, right? What is the reason?
Yes, sir.
What is the reason?
There will be more exposure to the estrogen, sir.
Yes. Okay. So similarly, the pregnancy will give a break or decrease the exposure to estrogen. Not only that, the continuity of exposure also matters. Uninterrupted exposure to estrogen is very, very risky compared to exposure with interruptions, right? So your pregnancy, lactation, those things are interruptions to estrogen exposure, which will reduce the risk actually. So early menarche, late menopause, so not consuming, not getting pregnant or unmarried status, all these are leading to uninterrupted estrogenic exposure. I usually brand it as uninterrupted estrogenic assault title. Okay, is right?
Yes, sir.
The breast is an organ which is being continuously assaulted by estrogen. Okay.
Estrogen.
If there is uninterrupted exposure or assault by estrogen, the risk becomes very much. Okay. Right. So hormone replacement therapy, you should know the difference between oral contraceptive pills and hormone replacement therapy. So comparatively, which is more risky, ma?
Hormone.
Yes. They say HRT is more risky than OCP use. So, but in our scenario or in our part of the world, hormone replacement therapy is very, very minimal. They do it for some orthopedic conditions, okay, like advanced cases of osteoarthritis and some skin problems. They use hormone replacement therapy, which is not usually the case in our part of the world. They do it in the Western world. So, in between OCP use and hormone replacement therapy, hormone replacement therapy carries more risk than OCP. Okay, right. Next slide.
Family history. No history of breast cancer in the first degree relatives. No history of BRCA related malignancies in the family like pancreatic, prostate, colorectal or ovarian cancer.
Okay, right. So there's a definitive family history which is to be elucidated in your history. Very, very important. Not only that, the amount of risk a patient carries with positive family history also depends upon the degree of relatives. Okay. So the first degree relatives, if they are affected, the risk is very much more rather than the second degree relatives are affected. Another thing is, any other thing you can tell regarding family history? The age at which a family member is affected also matters. Okay. Hmm?
Yes, sir.
You compare two situations where one of the relatives had a sustained cancer at 50 plus age, and another situation where another member has contracted the malignancy at a much earlier age, like 30 plus. The family member who is got cancer at early age, that person is at more risk of developing cancer. Okay.
Yes,
So
sir.
the degree of relative is all important, and also the age at which a family member gets cancer is also very important. The risk is more in such cases when it occurs in a early group in your family member, or the degree of relative is also less, first degree relatives. Okay, proceed.
Summary. A
Yes.
55-year-old post-menopausal lady presented with painless lump in the left breast for the past 6 months, which is not associated with pain, nipple
Yes.
discharge, nipple retraction with no metastatic symptoms. With the given complaints, I would like to examine the breast.
Yes. Proceed. Next.
General examination.
Hmm. Yeah, I will write to examine the breast for a possible malignancy, right? Okay.
Yes, yes, sir.
for for a possible malignancy, you can tell.
Yes, sir.
Okay. General examination. Yes.
The patient is conscious, oriented to time, place, and person. The patient is moderately built and moderately nourished. No pallor, no icterus, no cyanosis, no clubbing, no pedal edema, no significant generalized lymphadenopathy.
Very good. Next. We will skip this slide. We go to the next slide. Nothing will contribute to here.
Okay, sir.
Yes.
Local examination.
Yeah.
After after getting consent from the patient and in the presence of a female attender with maintaining adequate privacy, the patient was exposed up to waist. Examination of the
Yes.
left breast. Examined in sitting posture with arms by the side, arms raised above the head, arms at
Yes.
hip, leaning forward, and supine posture under bright light.
Very good. So this is very, very important. Okay. One by one, you
Yes,
should tell first with the patient sitting position with arms by the side, then arms raised above the head and in a leaning position. Then you should ask the patient to keep the hands in your hip and you should examine. But this last one, which I have told, most of the examiners don't emphasize nowadays. Right? So the purpose of asking the patient to keep the hands in the hip and ask him to push and examine is to make the tumor more prominent,
prominent.
not accepted by certain examiners. So it can be done in palpatory stage. So that need not be mentioned. Three standard positions are there: sitting position with arms by the side, arms raised above the head, leaning forward position, and of course supine position you can examine. Arms in the hip in inspectory you need not tell. Okay, right? Yes,
Inspection.
yes,
Arms by the side.
yeah,
Left breast is slightly higher than the right breast. Fullness is
yes,
noted in the upper outer quadrant of the breast. Skin
yes.
over the lump is normal. No
Okay,
POD orange appearance. No
yes,
ulcer, nodules, fungation and dilated veins. No
yes,
dimpling or puckering seen.
yes,
Nipple size 1 cross 1 centimeter, centrally placed. Left nipple is slightly higher than the right nipple. No retraction of nipple. No discharge from the nipple. No ulcer, cracks, fissure. Areola size 4 cross 4, brown in color, circumferential, no cracks, fissure and ulcerations.
Okay.
Arms and thorax, no edema, no visible nodes of fullness. Axilla, no visible nodes. Supraclavicular fossa, no fullness. On
So
raising
inside there is
arms
no
above
interaction
head,
with the nipple, right? Observed. What are the types of retraction, you know?
sir, circumferential retraction and slit retraction, sir.
Okay, slit like. Okay. Circumferential retraction is a hallmark of
Malignancy, sir.
malignancy, and it is due to infiltration of.
Lactiferous duct.
That's okay. What is the other reason for the other retraction of nipple?
Duct ectasia, sir. Slit like.
Slit like. So I don't know whether you have seen a circumferential retraction and slit retraction. Okay. So in slit like you will see a horizontal fold in the nipple which will be retracted like that. Whereas circumferential retraction, the whole area of nipple will be indrawn. Okay. So
Yes, sir.
sometime when you come to ward, if a case is available, you should examine or inspect and see. So for the time being, you should remember the causes for nipple retraction and the duct ectasia, which is in malignancy you get circumferential retraction. In a duct ectasia you get only slit like, only a horizontal fold like thing will be there which will be indrawn. Okay, right. So next question.
On raising arms above head,
Yeah.
both breast moves equally. Undersurface
Okay.
of the breast appears normal. No
Okay.
POD orange, dimpling or puckering. No
Okay.
retraction of nipple.
Okay. You have not mentioned one thing here. What is it? Mostly the tumor will become prominent when you ask the patient to raise the head, especially the upper quadrant tumors if they are there. So when you raise like that, that you will have to mention here. Okay.
Okay, sir.
Both breasts move equally. There is prominence of this mass, which is, you said it is in the upper outer quadrant. No,
Yes,
it
sir.
will usually become a bit prominent.
Okay, sir.
So you should, the change of position will make it prominent. You should, if it is becoming prominent, you can tell. Otherwise, you need not tell. Okay. But
Okay,
whether it is becoming prominent or not, you will have to mention. Yes. What is PV orange, Dr. Kartika?
sir, due to subdermal obstruction in the lymphatic, sir.
Due to
Lymphatic
tumor
obstruction, sir. Subdermal
by
lymphatic obstruction.
what?
Tumor, sir.
Tumor particles or tumor embolies. Okay. So
Okay,
spread
sir.
of tumor micro particles, they go and block and cause subdermal lymphatic blockade. Okay. So
Yes, sir.
two pores will be there. In between that, the subdermal lymphatics will be blocked and becomes edematous. So the intervening part will heap up with the pores being like pits. So it gives the appearance of PUD orange.
Orange
So
peel.
subdermal lymphatic blockage by tumor emboli. Okay. Or tumor
Yes, sir.
tumor particles. Okay. Right. What are the true signs of skin infiltration?
So
Skin.
one is POD orange,
Yes.
satellite nodule,
Yes.
and ulceration, sir.
Ulceration. Okay. So the terms which are not true involvement are only signs are dimpling,
Dimpling,
puckering,
puckering.
are just manifestations. Similarly, tethering. What is tethering?
It's same as dimpling, sir.
What is it due to?
Ligament of Cooper.
Yes, involvement of the ligament of Cooper by the tumor causes a string-like traction on the skin. It is not infiltration of the skin. In contrast, it is indirectly pulling the skin because there are fibrils. Ligament of Cooper from skin to the pectoralis fascia is there. It is normal structure, anatomical structure. If that string or the attaching fibers are infiltrated by the tumor, then it indirectly pulls the skin, causing a clinical manifestation called tethering. So tethering is due to involvement of Cooper's ligament. It is not a sign of true skin involvement. It will not change the stage of the disease. These are all standard questions which may be posed to you in your examinations. Okay? Whereas
Yes, sir.
puckering and dimpling என்ன அப்படின்னு சொன்னா they are visual manifestations of an underlying pathology. That's all. Okay? It can be a tumor. It can be an inflammatory mass. So it causes the backward pull on the skin, right? If the area of pull is very minimal, it is called dimpling. Sometimes what happens, more than one component will be indrawn, like a group of areas indrawn, it is called puckering. Puckering is only a volume, okay? It is a large area which is indrawn, it is called puckering. A small area which is drawn in is called dimpling. These are all only visual manifestations of an underlying pathology, which could be malignancy or other than malignancy is also there. But it should be very clear the true signs of skin infiltration are, as Karthika told, it is skin ulceration, beauty orange, and satellite nodules. Okay, very good. Next.
On leaning forward, breast falls equally on both sides. On contracting pectoralis major by keeping hands at hip, the lumps does not become prominent.
This need not be mentioned in, don't mention it in inspection part. We will confirm it in palpation only. Okay. What's the condition where, in which the breast may not fall forward on leaning forward position?
If it is attached to the chest wall.
Yes. Even what is chest wall involvement?
Ribs, intercostal muscles, serratus anterior.
Okay. It may not also fall forward if it is attached to the pectoralis major muscle, which is not a true chest wall involvement. But for that you have got other tests. Okay. Posterior attachment you should tell. The breast does not freely fall forward when it is posteriorly attached. Okay. Then if the discussion comes what is the posterior attachment, you can say either to the pectoralis major or into the chest wall. Chest wall means what are the structures you should tell. Okay, next. So at this stage you should remember any tumor which is attached to pectoralis major is not branded as 2,4-A. Okay. What is T4A?
Sir, if it is attached to chest.
Yes.
Chest wall, sir.
Chest wall infiltration, namely intercostal muscles, ribs, or beyond that. And more, sometimes the serratus anterior muscle infiltration is also called as chest wall involvement, but involving the pectoralis major is not classified as T4A. Okay, right.
Palpation. Not warm, not tender. Lump of size 7 × 5 centimeter. Hard in consistency. Ovoid in shape. Well-defined margins. Irregular surface. Felt in the upper outer quadrant. Fixed to the breast tissue. Skin over the lump is pinchable.
Yes.
The lump moves along with the breast tissue on contracting and relaxing the pectoralis major. There is no restrictions of mobility along the line of muscle fibers.
Yes, we should
no fixity to chest wall.
What you have told you should be given as 2 points. For mobility, you should independently tell. Okay?
Yes, sir.
The lump moves along with the breast tissue. That should be your one separate point. and on contracting, the purpose of both things are different. Okay. So
Yes, sir.
what is the movement? The lump is moving along with breast tissue. It does not independently move. Okay. What is the breast pathology which can move independently, freely mobile?
Fibroadenoma.
Fibroadenoma. Malignancy, when you try to move it, it carries the surrounding breast tissue along with that. That is one of the classical signs of malignancy, the movement of the tumor along with breast tissue, you should tell. And next one is on contracting and relaxing pectoralis major, there is no restriction of mobility along the line of muscle fibers. Okay, right.
Next slide.
No fixity to chest wall, right?
Nipple, no palpable mass deep to the nipple, no discharge
Yes.
from the nipple. Examination of axilla. A single node is palpable behind the anterior axillary fold, 1 cross 1 centimeter, which is firm in consistency, mobile, and skin is pinchable with normal skin surface. No other lymph nodes palpable. Supraclavicular fossa, no nodes palpable.
Okay, so how to explain a node is what she's actually giving. Okay, whether the node is simple or multiple, whether the if it is multiple, whether they are discrete or matted should be mentioned. Okay, a single or multiple. If multiple, they are discrete or matted. You should write. What is the condition under which the nodes are mated to each other? Tuberculous. Okay, mating of nodes at the earliest condition occurs in tuberculosis. What is the reason for mating of nodes? Janavi also texted is TB, correct. It is due to periadenitis we call. Okay, so a lot of nodes are there. The tuberculous inflammation typically causes what is called periadenitis, an inflammation around the nodes. So accompanying nodes here, periadenitis, they meet and they result in coalescing of the subsequent node, which is what we call as mating. Other things, if there is no inflammation around the node, then they become discrete. Okay, so you should be very sure. The reason for matted nodes is periadenitis due to the infection. Okay, right. So single or multiple, discrete or matted nodes, then the consistency firm, hard or soft, then you've got the mobility, tenderness, everything you should have a way of presenting, covering everything. Kartika, of course, has told everything about the lymph nodes. Okay, tenderness also you should tell. Okay, next slide.
Examination of right breast, normal.
I think you
Examination.
should also practice how to examine a lymph axilla. So when we used to take class in person, we will demonstrate how to, which are the groups for which you will have to stand in front of the patient. That I think you should go through text. I mean, DOS clinical methods and try. Okay, and practice. Yes.
Examination of right breast, normal. Examination of right axilla, normal. Examination
Yes.
of right supraclavicular fossa, normal.
Yes. Next slide.
Percussion, resonant note felt over parasternal areas.
What is the what are you going to make out by that? If it is dull,
No, it's not involving retrosternal.
retrosternal, right? What is the anatomical pathology you are trying to say if the percussion is dull? Retrosternal is the area. What is the pathological process you would like doubt? When it is dull, it implies enlargement of internal mammary.
Lymph node.
Are you there? Yes. So parasternal percuss பண்ணும்போது obvious dullness is there. You should doubt the presence of internal mammary node enlargement. Okay, that's what.
Yes, sir.
So retrosternalன்றது ஒரு ஏரியா. அந்த ஏரியாவில் என்ன நோடு இருக்கும்? It is internal mammary group.
Internal mammary lymph nodes.
Yes. So if it is dull, immediately you should tell internal mammary group of nodes may be involved or enlarged. Okay, next.
Other examination. Other system examination.
Anything specific? Nothing?
No, sir.
No contributor means we can go to the next slide. No problem. Yeah. Just give the summary, yes.
A 55-year-old postmenopausal woman presented with a lump in the left breast since 6 months, rapidly progressive in size, with no history of pain, nipple discharge, and nipple retraction. On examination, 7 × 5 cm hard lump felt in the upper outer quadrant of the left breast, with irregular surface, with no fixity to skin, pectoralis major muscle or chest wall, 1 × 1 cm single ipsilateral mobile lymph nodes palpable in the axilla with firm consistency.
Yes. How do you finish?
Provisional diagnosis.
Yes.
A 55-year-old postmenopausal woman with carcinoma of left breast. Clinical staging CT3N1M0.
Okay. So go to the previous slide. One important thing which you should mention here is the see you nicely summarized first the history part, right? Yeah, 50-year-old postmenopausal lady presenting with a relatively short duration of painless breast in the left, painless lump in the left breast, which is rapidly progressive without nipple discharge and nipple retraction, which on examination reveals a hard lump with irregular surface, which moves along with breast tissue. We should put that is one of the cardinal signs of malignancy. So see a breast or lump. When do you say that see a breast is a lump? The lump is see a breast. It should be the classical signs of malignancy are irregular shape, hard consistency, moving along with breast tissue, involvement of axillary nodes, skin, nipple retraction, okay, skin changes. All these are the classical signs of malignancy. So your summarization, the mobility along with breast tissue should be emphasized. Okay,
Yes.
right.
Okay, sir.
Yes. So how do you classify this CA breast? When we behind the class itself, I told all your breast cases may be classified into 3 types according to the extent of involvement of surrounding tissue or the spread of disease. So what is the type of CA breast which you are presenting?
Sir, this one is locally
Yes,
locally
exactly.
advanced breast carcinoma.
Yes. So T3 and more becomes locally advanced, and also N1 is there. It is definitely a LABC case. When do you call a CA breast as early breast cancer?
Sir, if it is tumor size is less than 5 cm.
Yeah. A tumor which is confined to the breast and T2 or less. Okay. So the nodal involvement should not be there. It should be confined to the breast, and even if it is confined, it should be T2 or less. Then only it is called early breast cancer. Okay. The moment N1 comes, it is going on to the other area, regional area. So I think T2 N1 also brands as LABC only. Okay, so T1N1 may be classified as early breast cancer, but anyhow, involvement of node itself will make the disease to be not to be classified as early breast cancer, but this is definitely a locally advanced breast cancer. Okay, right. What do you do for the patient?
Sir, I would like to investigate the patient to confirm my diagnosis, to
Yes,
stage the disease, and
yes,
for the treatment purpose.
very good. So, what are your investigations?
Management, protein investigations,
Yes.
blood total count, differential count, ESR, hemoglobin, blood grouping and typing,
Specific investigations to confirm the diagnosis will come. Yes.
specific investigations, mammogram,
Yes.
FNAC, core needle biopsy,
Okay. What will be a
staging
mammogram?
sir, microcalcification we can see,
Okay.
uh, distortion in the structure,
Yes. Architectural distortion, then mass effect, then calcifications, right? Microcalcifications. Hmm? What is the shape of calcifications usually is very significant.
more than 0.5 mm.
I said shape.
So,
Any particular shape is very suggestive of malignancy. They say popcorn classification. It is due to non-malignant condition. The classifications which are typically malignant are stellate classifications, they call it. Stellate means starlight. Okay. So microcalcifications which are stellate shaped are very suggestive of malignancy. So when you do a mammogram, it is a soft tissue X-ray, right? There are two plates in which the breast is compressed in between, and mammographic figures are taken. And what are the common use of taking mammogram?
such screening purpose,
No, views.
views,
X-ray was only
crano,
anterior. Yeah,
yes, sir, cranocaudal and mediolateral oblique.
very good. So craniocaudal is like this from up to down, and mediolateral oblique is the other view. So the breast is compressed between two plates using low amperage uh, uh, radiations, and it is taken and the picture is examined. Okay, so the findings of malignancy in a mammogram are architectural distortion. As a whole, the architecture of the breast will be distorted. Then when you find a particular area, there will be a mass effect. Number two, and in that mass effect, if you go deep and observe, there will be microcalcifications which are present, which are mostly stellate type microcalcifications are very suggestive of malignancy. Okay, kindly remember the word stellate calcifications. Okay, right. So mammogram is one. Then
Core needle biopsy.
FNAC biopsy. Okay, you would like to do both or one?
Sir, we can do core needle biopsies.
Yes. What in all information you get in FNAC, you can get it in core needle and more information. So core needle biopsy itself is sufficient. Okay. What are the advantages of core needle biopsy over FNAC?
Sir, it can tell about the receptor status
Very good. Hormonal
and
receptor status can be studied only with core needle biopsy, not by FNAC. Okay, number one. Anything else?
grading of the disease.
Grade of tumor is very, very important. Very good. Another,
And
yes.
invasion or in situ, sir.
It can differentiate between in situ and invasive carcinoma. Kindly remember three advantages of core needle biopsy. It can differentiate between in situ and invasive cancer. It can give an idea about the hormonal receptor status, and you can
Grade
also
of this.
assess the grade of the tumor by gore needle only. FNSA cannot help you in all these aspects. These are very important questions which an examiner may ask, you should remember. Okay, right. So do not use the word true cut biopsy because some examiners are not fond of the word. So true cut biopsy is a company name. புரியுதா?
Yes,
ட்ரூ
sir.
கட்ன்றது ஒரு கம்பெனியோட பேர். ஸோ some people do not like it. So core needle biopsy is the correct generalized term. Right. Next one.
Staging investigations, chest X-ray, USG abdomen, liver function test, X-ray skull, pelvis and spine, mammogram of contralateral breast, CT test,
Okay.
C15-3 CEA.
Okay. Right. MRI is helpful in any condition. Yes.
Micro
Yes, ma.
osteolytic secondaries in bones, sir.
No. In breast area, MRI is helpful in specific situation. Anybody
High
who
risk,
knows
high
the
risk
answer?
people.
Identity. So Kirtana is saying differentiate between multifocal and multicentric lesion. So it is not specifically because of MRI. Even a mammogram can tell about multifocality and multicentric. We will discuss about that. MRI is more helpful in young women, Janavi says. Multimodal lesions, multifocal, dense breast, young women, sense breast. Yes. So there are two indications for MRI. Okay. It is indicated for younger group where the glandular component is more. There the mammogram may not be very useful. And Janavi has correctly told implant. Okay. So MRI it is more useful in case of a recurrent breast mass, where scar or recurrence has to be divided. Okay, once you operate or intervene a breast, the architecture becomes destroyed or altered. So அடுத்த தடவை ஒரு சின்ன அந்த இடத்துல ஏதோ ஒரு ப்ராப்ளம் வந்ததுன்னா அதை எக்ஸாமின் பண்ணும்போது வில் ஹாவ் a doubt whether it is a scar tissue or a recurrence. So in that situation, MRI is very, very useful. Kindly remember, MRI is useful for younger age group where the glandular component is very, very abundant, making mammogram not very much dependable. So younger women with very glandular breast, number one. Number two is in a already intervened breast where to differentiate between a scar tissue and recurrence, MRI is the best modality of treatment, right? So now that our students have told about multifocality and multicentric, Karthika, can you tell the difference between multifocality and multicentricity?
Sir, multifocal means the two lesions will be in the same quadrant.
Yes.
Multicentric means in a different quadrant, sir.
Yes. So ஒரே குவாட்ரண்ட்ல நிறைய இருந்ததுன்னா it is called multifocal. Across the quadrants, if there are more lesions, then it is called multicentric. What is the importance of making out multicentricity or multifocality? Why is it important?
Primary.
Lobular CA, Janvi, you can unmute yourself just for 1 second and answer me.
Yes, sir.
You have given lobular CA. Very good. I appreciate. Is it only multifocal, multicentricity or something else?
There's loss of each other in mutation. The tumor cells can get it. I don't know.
Yes, lobular CA, you got a very valid answer, but you should also make sure that lobular CA is bilateral occurrence. The other breast also is
Okay.
involved. That is a peculiarity of lobular CA. Okay, lobular CA has got bilateral breast involvement. Okay, so we will come back to Kartika. You tell me now, what is the importance in making out multifocality or multicentricity? Gauri
Sir,
is excellently answering. She said conservative surgery. Do you agree, ma?
yes, sir.
Yes. You should have answered it before itself. Sir, the multicentricity, multifocality are very important when you contemplate on doing a breast conservation surgery. Very, very, very important. Don't ever forget, because multicentricity, multifocality are contraindications for breast conservation surgery. Okay, va? So, ஒரு breastல multicentricity, multifocality எதுக்கு பார்க்கணும்னா, if the patient is eligible for breast conservation surgery, we should make sure that the disease is not multifocal or multicentric. The answer should be immediate, right? So,
Yes, sir.
the importance of assessing multifocality or multicentricity is to decide on breast conservation and otherwise eligible patient. Am I clear?
Yes, sir.
Yes. Okay, go ahead. So, CT chest, mammogram, yeah. Okay.
Treatment.
CT spine you would like to see? Go back to the slide. X-ray skull, pelvis, spine. X-ray is enough.
Yeah. CT also we can take.
So nowadays they either do bone scan or a PET scan to assess the skeletal involvement. Okay, va? So in the past they have been doing X-ray skull, pelvis, and other things. Now they defer doing it. In all cases of LABC, where the situation is like T3, N1, other stages, then they immediately go to a bone scan. You can bravely say it is a bone scan. So this is a LABC, sir. I would like to see bone involvement. I will do a bone scan, or you can do a PET scan as the other alternative. It will also make out the bone metastasis will be picked up. Okay, va?
Yes, sir.
So bone scan has become a part and parcel of evaluation of an advanced disease like this. Very early breast cancer, for example, there is a 2 centimeter lesion without a nodal involvement, you need not do. But this is a T3N1, obviously locally advanced. All the more possibility of some skeletal metastasis has to be kept in mind. You can do a bone scan, can be confidently mentioned here. Okay. So
Yes,
X-rays all become they are not reliable nowadays. Right. Go ahead. In terms of bone involvement, I'll just ask a few questions. Which are the areas of the bones where you would like to look for secondaries in order of preference or priority?
Sir, lumbar vertebrae,
Very good.
long bones, femur.
Yes. Long bone ends like femur, tibia. Yes. That is the second frequent.
Ribs and skull.
Yes. Again, the dorsal vertebrae will come next. Okay.
Yes.
Lumbar vertebrae, long bones, dorsal vertebrae, then ribs, then skull, then other areas. Okay. Right.
Yes, sir.
How does the secondaries go to lumbar vertebrae, ma?
Batsten's plexus, sir. Batson plexus.
Batson's. BATSON''S. Batson's plexus. Okay. From breast, what is the route they take?
Posterior intercostal vessel.
Very good, excellent. From the breast, immediate veins which the tumor emboli enter are the posterior intercostal veins, which will go in and drain into the azygos veins. Okay, azygos veins will have connections with what is called an internal vertebral plexus or the Batson's plexus, which will retrogradely disseminate the tumor emboli into the lumbar vertebrae. They say it happens only when the patient strains or does Valsalov maneuver. They are not usually, they don't go when they will be retrogradely going into the lumbar vertebrae when the patient strains or does Valsalva maneuver. Okay, so tumor, posterior intercostal veins, azygos veins, then the Batson's plexus. That is the route which is taken by the tumor. Right, ma? Okay.
Yes, sir.
Yes.
Treatment: neoadjuvant chemotherapy to downstage the tumor, modified radical mastectomy in the left breast with chemotherapy and
Yes.
radiotherapy.
Okay. Right. So neoadjuvant. That's all. Is the treatment complete? Yes.
Hormone.
Hormone. The voice is not clear.
Hello, sir. Am I audible?
Now I can hear you. Yes, tell me.
Hormone therapy, sir.
I accept your first part of it, neoadjuvant chemotherapy, followed by modified radical mastectomy, followed by adjuvant chemotherapy plus
Radiotherapy.
plus.
Hormone therapy.
You should tell when you will give hormone therapy, depending on.
Sir, if ERPR status, sir.
If the ERPR status is positive, you will go on to hormonal therapy. What is the hormonal therapy of choice in this case?
Sir, aromatase inhibitor.
Why, ma?
Sir, as a patient is old age, she is postmenopausal. Estrogen will be coming from peripheral conversion of the fat, sir.
Very good. So the functioning ovary is not there. So you cannot use tamoxifen. Tamoxifen is indicated in a lady with a functioning ovary. Here, the source of estrogen, though it is ER positive, estrogen receptor positive, the estrogen is obtained from conversion from peripheral fat by aromatase. Okay, wow? If you inhibit the aromatase, there is no conversion of fat into estrogen, and the severity of the disease is reduced. Okay, wow? So postmenopausal, it is aromatase inhibitor. Premenopausal, functioning ovaries, you can choose tamoxifen. Okay?
Yes, sir.
What are the situations where radiotherapy is indicated in a CA breast? When all you will take to radiotherapy. Yes.
Sir, if the margins are positive after surgery.
Very good. One condition is post-operatively, if the resected margins are positive, by all means you should give radiotherapy, number one. Number two?
In case of breast conservative surgery, sir.
That is different, yes. That is one thing which is not in our area now. We are having LABC. That is an absolute indication. Radiotherapy is compulsorily given for breast conservation. There is no breast conservation without radiation. Okay? If for any other reason you cannot give radiation, you should not go in for breast conservation. That is a separate topic. Here, this is not a breast conservation surgery, but still, what are the conditions where you give a radiotherapy? One, you have said positive margins, resected margins. Yes.
Metastasis to axilla.
That
More
becomes
than
palliative.
metastasis to more nodes, sir, lymph nodes.
Mere presence of axillary nodes itself nowadays is considered an indication for radiotherapy. Okay, va? Sometime back they have been telling 4 more nodes or more in the axilla, you should give radiotherapy. That was the concept sometime ago. Now they say positive nodes, any number of nodes in the axilla, if they are positive, you go and give radiotherapy. So second indication is axillary nodal
Positive.
involvement. Yes. Then there are 4 conditions where radiotherapy, adjuvant radiotherapy should be given. Positive margins, axillary nodal disease presence, then
High grade, sir.
any
High grade
tumor. Good, very good. High grade, all high grade tumors should be given adjuvant radiotherapy. Fourth one, any tumor T3 or more. Okay?
Yes, sir.
Axillary இல்ல resected margins negative இருக்கு. But you are clinically that tumor is T3 or more. Okay?
Yes, sir.
Any tumor which is T3 or more, positive resected margins, axillary nodal disease is present, then high grade tumors. You remember 4 things. In all these conditions, radiotherapy should be given. And of course, the broad other side where breast conservation surgery is done, we should give radiotherapy. Okay?
Yes, sir.
Right. So I think it's time. We'll wind up with this. Next class, when we discuss breast, we'll go more about the procedures. We'll make the fast presentation, one of you will make sometime in next class. We'll go ahead and complete what are the operative procedures, like the variants of mastectomy, modified 9, what is the reason, other things we'll discuss in the next class. Okay? Right.
Yes, sir.
Thank you. Tomorrow, what class do you want to discuss?
Sir, tomorrow's topic diabetic ulcer, sir, presented by Karishma.
Diabetic foot ulcer, right? Okay.
Yes.
Okay. We'll start by 4 tomorrow.
Yes, sir.
Okay. Goodbye.
Thank you, sir.
Thank you, sir.
Thank you. Thank you. Thank you very much.
Thank you, sir.